Hello, everybody, and welcome back to NBME 28. These are original questions, but it's everything that I think you should know by the time you finish NBME 28. Now, in this question, I'm going to have to talk about sensitivity, and sensitivity is simply the true positive rate. And the way to think about this is if you're dating somebody and they are a sensitive person, you think, oh, that's truly a positive trait. But if you're dating somebody and they have to specify who they're dating, that's a truly negative trait. Like, who are you dating again? Let me think. Negative, red flag, stay away. And the only other thing to know about this question is that screening tests must be highly sensitive. And the reason why is that will minimize the false negatives and rule out the disease. And the way you remember that is SNOUT. Sensitivity for SN rules out the disease. So you have to be highly sensitive, which is, again, a truly positive rate. Because if that truly positive sign is high, then it minimizes the false negatives and it rules out the disease. Also, predictive values, they change with the disease prevalence. And so in high-risk patients, a low sensitivity screen is especially dangerous. So the big takeaway on this one is a high sensitivity will rule out, and the way you remember that is SNOUT, because sensitivity maximizes the true positive detection, and specificity minimizes the false positives. You remember that one by SPIN. Specificity rules in the diagnosis because it minimizes the false positives. And the reason I've got these awesome little images over here on this side of the screen in the bottom line is that colorectal cancer begins as adenomatous polyps. You detect them early through a colonoscopy. But if you just do a fecal oral blood test, then you can miss the non-bleeding lesions. A colonoscopy is the gold standard, has high sensitivity and specificity. But if you just did a fecal occult blood test, you miss the polyps and the bleeding tumors, and you might have a false negative. You might say, oh, you're totally fine. But if you don't do the colonoscopy, you won't know that for sure. And so here we have a 59-year-old man, it could also be a woman, hence this photo, comes to the clinic for routine evaluation. His or her father died of colon cancer as well. The patient is asymptomatic and has no personal history of gastrointestinal disease. He or she requests to avoid invasive procedures and instead do a stool-based screening test. However, the physician is like, hey, that's not ideal. And what is the reason why? The answer is C, the poor sensitivity. And if we look here, sensitivity rules out the disease, and that's what we're trying to do. And this test that he wants to do does not have a high enough sensitivity. So the rationale is that we have a family history of colorectal cancer. That means we have a high pretest probability. And so this fecal occult blood test is not going to be good enough because it's not sensitive enough. If it's low sensitive, then it might have a false negative. You might be like, oh, you're totally fine, even though you're not. And that's the reason that we want to do a colonoscopy in this case. False positive means you have a low specificity because the problem here is missing cancer. If you flag it and you're wrong, no big deal, you don't die. But if you miss it, then you do die. That's the way to think about these things. All right, moving on to question 22. Here we have a 44-year-old man developing acute kidney injury after several hypotensive episodes during surgery. And this question is really just getting at some basic science stuff, and so it could really be any demographic. But just so that you guys can visualize this particular scenario, I'm going to go ahead and update this image on the left. That will happen soon. Over the next 2 weeks, there it is. Over the next 2 weeks, his renal function gradually improves. This improvement is most likely mediated by which of the following mechanisms? Okay, so he's improving. And again, I mentioned this is a basic science question. And the two most relevant facts you need to answer this question are, one, most of your hepatocytes and renal tubular epithelial cells are actually in the G0 phase, the quiescence phase. That's basically the state of inactivity or dormancy. And that's where they're at in normal conditions. But if you get injured, then these mature cells are going to regenerate by being recruited from the G0, the quiescent phase, back into the cell cycle. And the cell cycle, as you know, goes from G1 to S to G2 and then to M. And so this is the inactive state, the G0. And basically what you need to know is that this person has stable cells until the injury occurs. You know, in your hepatocytes, renal tubular epithelium, and your smooth muscle, they're all normally in the G0, but they can re-enter into the cell cycle after the injury. All right, so the answer is C, recruitment of the renal epithelial cells from quiescence, which means inactivity or dormancy. Let's look at the other reasons why these other answers are false. Bone marrow-derived stem cells does not contribute to the renal regeneration. Resident immune cells do not replace the epithelial tissues. And a shortened G2 to M phase doesn't help if they're quiescent to begin with. And transdifferentiation, they don't become renal epithelium. They're organ-specific, and so they stay in their lane. And the mechanism is important. You have injury, and how is this actually able to be signaled? Well, the answer is growth factor signaling. So HGF, EGF, TGF alpha, that kind of stuff. That's the growth factor signaling, and that causes the quiescent cells to transition from G0 to G1 to replication. And so this is going to be associated, they'll ask you about this on test day, with liver regeneration after a partial hepatectomy. It's because the hepatocytes are re-entering into the cycle, not the stem cells. Also, they'll ask you about a kidney recovery after some sort of acute tubular necrosis. So for instance, there you could have your proximal tubule cells. Those replicate to restore your architecture. And so the injury leads to the loss of the cell-to-cell contacts. And once those guys don't have that contact, then the growth factor is released and then the cell cycle goes into re-entry mode. So just to be very, very clear on the pathophysiology, what's happening here is that in our normal cells, most of your hepatocytes, and again, hepatocytes is just a nice way of saying like a liver cell, and your renal tubular cells, they all start in G0. And that's the normal phase. Like if you're just sitting in your body, that's what you see. Then you undergo some sort of a toxic or ischemic injury, and that causes some cell loss. And the surviving cells receive growth factor signals. And we discussed what those growth factor signals are. Here they are right there. And the surviving cells receive those signals, and then they re-enter into the cycle at G1. And this replication restores the organ mass and the function. So you have stable cells, and then you use the growth factors, and then stem cell activation is going to be actually like a minimal repair compared to the existing mature cells that are actually there in the G0 quiescent phase. So another big trap on these questions is you don't want to confuse decreased apoptosis or a shortened cycle time. What actually happens is our G0s just go, okay, forget this, I'm going to be a G1 now. And they're mature, they're in the hepatocytes and the renal cells. Okay, so that's how this works, a basic science question. Now we're moving on to 23. All right, so now we're going to be tackling an ethics question here. So we're going to change this so that it's just some adolescent. It could really be any demographic though. And what's happening is somebody's going to come in and they're going to say, hey doc, I'm worried, I don't know what to do. And the ethics question here is going to be getting at asking open-ended questions to clarify the concerns. So just to show you it's a different demographic, here we have a 9-year-old girl is brought to the pediatrician because her mom is saying that something's wrong. And the correct answer is, tell me more about your worries and what you're eating. Always ask open-ended questions to clarify and understand this better. Don't do unnecessary testing. Don't just start educating them. Try to figure out exactly what they need. And most of the times, especially in pediatrics, like half of the medical complaints are just going to be parental concerns, not actually the child themselves. So it's actually a very important skill. All right, so here it could be a different demographic, but we're using a 45-year-old man, could be a woman as well, but I'm going to go ahead and change that in the upper left corner. And they have a history of psoriatic arthritis, presenting to the clinic with persistent fever, weight loss, and chronic cough. He began treatment with the new medication 6 months ago that significantly improved joint pain and skin lesions. Chest x-ray reveals bilateral upper lobe infiltrates. Sputum shows as positive for acid-fast bacilli, and the mechanism of action in this patient's medication is most likely interfering with which of the following processes. Okay, so here are our answer choices. And to kind of get at this question, I want to talk about the pathophys. Let's talk about Mycobacterium tuberculosis. That's what persists within intracellularly. That persists intracellularly within the macrophages. And there's this thing called TNF alpha. And TNF alpha, that goes ahead and it activates the macrophages where it drives granuloma maintenance. And so if we give anti-TNF alpha, if we block that TNF alpha, then we're going to block that granuloma disintegration. And so this guy's got some chronic coughing. He began this medication that seems to be reactivating his tuberculosis. That seems like the mechanism of what's happening in this patient. And they're going to be saying, okay, well, why is this occurring? And the answer is the sequestration of the pathogens through granuloma formation. So they're using anti-TNF alpha therapy that has reactivated latent tuberculosis due to the impaired granuloma maintenance. TNF alpha is very important for walling off the TB, and if you don't have it, then it can escape and reactivate. Interleukin-2 is associated with hot T-bone steak, so it's T-cell activation. IL-5 is relevant in parasitic infections, not in TB reactivation, and germinal sensor B cells. For that, you would use rituximab and anti-CD20, not TNF blockers. And the complement-mediated lysis is not the mechanism for clearing intracellular TB. So as we discussed, this TNF alpha maintains the granulomas, and that's super crucial for containing tuberculosis. If you think about tuberculosis, it's active inside of your body, and TNF alpha is the reason that it's contained. It maintains that wall, so to speak. And if you give them anti-TNF therapy, that'll disrupt the granuloma integrity, and that leads to reactivation. They could try to give you other trap answers, like they could say, hey, what about interleukin, 8? Well, interleukin 8, that attracts the neutrophils, but that would not be getting at the main mechanism here. They could try to say B cells and antibody responses, but that's not going to be relevant. Rituximab isn't relevant here. The TNF alpha does not directly kill the bacteria either. And if they said something else like, IL-10, well, that would dampen the immunity, but it's unrelated to the granuloma maintenance. And so granuloma maintenance is really going to be most affected by that TNF alpha. And so you inhibit it with your anti-TNF alpha therapy. And that actually gets at the disruption of that granuloma, causing the reactivation of tuberculosis. So in this patient, you have to recognize that they have tuberculosis, they have case-eating granulomas, infliximab, monoclonal antibody inhibitor, you have the cough, fever, night sweats, and a lack of TNF alpha causes the poor macrophage containment of the tuberculosis, and that's why this person got sick. Cool. All right, in our next question, we have a relatively young boy is brought to the emergency department after experiencing persistent bleeding several hours after a minor bike accident that resulted in a cut on his history of easy bruising and missed multiple school days due to joint swelling. Physical exam to his large, swollen right knee. Coagulation studies show normal PT. PTT is prolonged, so that's the intrinsic pathway. When mixed with normal plasma, it corrects. The sample from the maternal uncle shows no correction in a PTT when mixed with this patient's plasma. Which of the following is the diagnosis? All right, so for this one, we have to know the coagulation cascade, and we also have to know some basic science facts about this condition. So first of all, let's talk about hemophilia. We'll talk about hemophilia B. That is an X-linked factor 9 deficiency, and that causes a prolonged PTT with a normal bleeding time and platelet count. And mixing studies correct the PTT if the missing factor is supplied. In the uncles, it wouldn't if he has the same condition. So if it corrects with plasma mixing, that means it's a true deficiency, not some sort of inhibitor. And the mechanism here is just factor 9 deficiency, which blocks the activation of factor 10, and that stalls the formation of thrombin. And this is X-linked inheritance, and so boys are often going to be affected, and family history is going to have a male bleeding disorder if it's hemophilia B for boy. Hemarthrosis and deep tissue bleeding is the hallmark of hemophilia versus mucosal bleeding. And so the treatment is really just going to be recombinant factor 9. And again, it's just a simple deficiency. You've got a deficiency of factor 9, so you have impaired activation of, if you remember the coagulation cascades, that means you can't activate the factor 10. And if you can't activate factor 10, you have decreased thrombin. Decreased thrombin means decreased fibrin clot stability. And then you have prolonged bleeding after something like a tooth extraction or circumcision. That's why usually they're going to be a younger patient. So deep muscle bleeds, hemarthrosis, which is the bleeding into a joint causing the joint pain and swelling. That's why you miss several days of school. Now, von Willebrand's would actually show a prolonged bleeding time, and that's the reason that's not the answer. And we can kind of scroll down and see some of these explanations here. Hemophilia A would be factor 8 deficiency. It would not correct because they both lack the factor 8. We mentioned von Willebrand's has a prolonged bleeding time because it stabilizes factor 8. Antiphospholipid antibody syndrome would be a lupus anticoagulant, be thrombosis, not bleeding. DIC would have decreased platelets, increased both of these, and also increased D-dimer. And so oftentimes these kids don't even know that they have this disorder until they go to the dentist, and then they start bleeding like crazy, and then it's like, okay, you have hemophilia type B. But typically you can find that through B as in boy looking through the family history. Hemophilia A is an 8 deficiency. Mixing with this patient's plasma does not correct. So here we have an intrinsic pathway defect, X-linked, and it's corrected by mixing. Just to make this super simple about hemophilia A versus B, mixing studies will distinguish between them. Hemophilia A versus B in a clotting inhibitor like lupus. Basically, you add normal plasma, then you recheck the PTT. If it corrects, you have a factor deficiency like A or B. And if PTT does not correct, then it's a clotting inhibitor. So you actually get that plasma from a known hemophilia patient and find out the missing factor. So look out for the big things here would be like trauma, easy bruising, hemarthrosis, and that's the reason why this kiddo was missing school. Here we also have the bottom line, prolonged PTT, and let's go to the next question. All right, next, alpha blockers. Here we have a 59-year-old man started on some new medication for hypertension. A few days later, he's feeling lighthearted when standing up quickly from a seated position. Blood pressure is 134/84. Heart rate increases from 72 to 96. Medication he's taking most likely decreases which of the following physiologic parameters the most. All right, so there is a picture of our guy, and our answer is peripheral arterial resistance. And we have to know why. And basically what we're doing here is we are turning down the squeeze. This is an alpha-1 blocker. So alpha-1 adrenergic receptors on the arterial smooth muscle, they raise the systemic vascular resistance and it blocks. And if you block them, you will lower the SVR. And if you lower the SVR, then you're going to be decreasing the mean arterial pressure. And so the venous alpha-1 tone will fall too, but then the dominant acute blood pressure effect on the alpha-1 blockade is then dropped in the peripheral arterial resistance. So arterial vasodilation, the alpha-1 blockade relaxes the arterial smooth muscles and that decreases the systemic vascular resistance. So you have less afterload and lower MAP, mean arterial pressure. So why would you even give these guys? Well, BPH, prozazine, doxazosine, these are alpha-1 blockades that relax the prostatic urethral smooth muscle, lets it just chill out. But that same mechanism will also lower the SVR. And one thing that they like to test you on is that you can have reflex tachycardia because the baroreceptor, it's like, oh, look at that MAP, look at that mean arterial pressure going down from the decreased SVR. And it's going to say, okay, well, we have to increase the contractility. So that's reflex tachycardia. And they do that via the beta-1. And that's like a compensatory mechanism. It's not going to be a primary mechanism. So they're able to drop his blood pressure and the heart rate increases because of that reflex. So we have alpha-1 antagonism. And the alpha-1 antagonism actually decreases the GQ signaling in the vascular smooth muscle, and you get arterial dilation. So you decrease the SVR and you decrease the mean arterial pressure, and you have venodilation. And so the key features, you'd have Heart rate contractility can rise, but the SVR is definitely going to drop, and you have an orthostasis risk. That's the reason why this person was like feeling a little bit woozy when he's standing up. That's highest with the first dose of the volume depletion, because the beta 1 is also going to be driving the heart rate and the contraction, whereas the alpha 1 is going to drive the vascular tone. All right, so here we have a 19-year-old college student, could be a male or female. So I've shown a picture of a female here. Later, I will put up another demographic so you don't get fixated on that, but it'll be of a 19-year-old college student. Evaluated for decreased exercise tolerance. He denies chest pain, syncope, or prior illness. He has never smoked. On exam, his lungs are clear. Cardiac auscultation reveals a grade 2 out of 6 systolic ejection murmur at the left upper sternal border. Also a widely split heart sound that does not vary with respiration. Which of the following best explains this patient's findings? So a lot of this stuff is super pathognomonic. We have a fixed, widely split S2 that does not go away with inspiration. So it's going to be an atrial septal defect with a left-right shunt. And you have increased right-sided flow. That delays the pulmonic valve closure. And so you have a P2 delay. So here's our 19-year-old college student with a decreased exercise tolerance, denying any chest pain. And really what gives this away is the fixed split S2. The right ventricle stroke volume is going to be chronically elevated because of that left to right shunt. And so the P2 is always going to be delayed regardless of the respiration. And so the answer is a defect in the endocardial cushion development. You might be saying, okay, well, why is that the case? Well, that's what you have to memorize for ASD. It's the ostium primum or secundum. So you have the left to right shunt, and then the right heart is overloaded. So you have that fixed S2, the split S2. Pathognomonic arteriosus is going to be machine-like. We all know that. It's not fixed. S2, pulmonic stenosis. The splitting would be respiratory dependent, not fixed. VSD is a hollow systolic murmur at the left, the lower left sternal border. Tricuspid regurgitation, hollow systolic murmur, increasing with inspiration, not a fixed S2. And this is about 1 out of every 1,500 adults have some sort of ASD, and it's that fixed, widely split sound. And that happens because of the increased blood through the pulmonic valve. And later on, you can have the development of Eisenmenger syndrome, where it reverses from that left to right shunt. Next, we have a 61-year-old obese man presenting for evaluation of chronic cough and intermittent hoarseness. He reports worsening symptoms over the past 6 months, including a sour taste in his mouth after meals. All right, so there's our more obese man. He's got retrosternal burning, so that's GERD, yep, and he has been non-compliant with his medications. Upper endoscopy reveals a salmon-colored mucosa extending proximally from the gastroesophageal junction. Biopsy of the affected area demonstrates mucin-secreting columnar epithelium with scattered goblet cells. Which of the following is the best histologic finding? All right, so this is going to be GERD gone kind of rogue here. This is Barrett's esophagus. And what you should be thinking of for this condition is intestinal metaplasia with the goblet cells. And you have squamous epithelium of the distal esophagus. The distal, they're always going to say something like the lower, maybe they'll say the lower third of the esophagus, something like that to denote that it's going to be the distal esophagus. And it adapts to the chronic acid injury by transforming the columnar epithelium. And so it starts to resemble that intestinal mucosa. It's like, hey, you're doing things that the stomach is doing, so let me give you some of that good intestinal mucosa. And the goblet cells are trying to help, right? They secrete the protective mucin. And so you have a premalignant lesion, which then leads to adenocarcinoma, and that metaplasia increases the risk of dysplasia and eventual adenocarcinoma. And so you know that this is GERD because of that retrosternal pain, the repeated acid reflux, and the smoking and obesity also increases the intra-abdominal pressure and acid exposure. So smoking is bad, obesity is bad, GERD is bad. The hiatal hernia also predisposes an individual to a reflux. And then adenocarcinoma, well, Barrett's is going to be the strongest risk factor because of that dysplastic intestinal epithelium that progresses to malignant transformation. So you have chronic acid reflux that damages the squamous epithelium. Then you have adaptive metaplasia that replaces the squamous with the intestinal type of the columnar cells. And then the goblet cells are like, hey, we got to get in there and do some protection. And they essentially supply the esophagus, the lower part of the esophagus, with intestinal type material, the columnar cells. And then the goblet cells produce the mucin for protection, but they do that pretty much at the cost of genomic stability. And so you have ongoing injury, dysplasia, and that all increases your risk for adenocarcinoma. And so the big risk factors here are going to be GERD. Look out for GERD. Acid reflux, the biopsy would show columnar epithelium and maybe even some goblet cells, and the risk is adenocarcinoma, not necessarily your squamous cell carcinoma, but yes, certainly some metaplasia. And so our answer is going to be intestinal metaplasia of the esophageal epithelium. Here's the brief explanation. We kind of went over this stuff. Why is it not A, squamous hyperplasia? Hyperplasia is reactive, does not explain the goblet cells. Chronic inflammation of the lymphoid, that's chronic gastritis, so maybe H. pylori, but not GERD and metaplasia. Squamous and keratin is squamous carcinoma that's not related to GERD. They'd be smoking, alcohol, and a mid-esophagus, not distal esophagus. Again, they're going to say the lower third. Adematous transformation of the submucosal glands is not going to be involved in Barrett's because that does not undergo that intestinal metaplasia that we talked about. And this is going to be 1 in 10 patients who have chronic heartburn are later going to develop a condition that rewires that cellular esophagus and turns it more into mucosal cells. All right, that's called Barrett's esophagus, and that change is intestinal metaplasia. because those goblet cells are in the place that they shouldn't be. So it's that C intestinal metaplasia of the esophageal epithelium. Okay, so that's Barrett's esophagus for you. All right, this is a good question. And this technically could be a man, but the practice question I'm giving you guys is going to be a woman just because I want you to be a little bit more familiar with how this is most commonly going to be presented on the exam. So we have a 43-year-old woman presenting to her clinic, her PCP. I'm going to give you kind of an updated photo there. With progressive fatigue and exertional shortness of breath over the last 3 weeks, she has no cough or chest pain. Vital signs are normal. Pulmonary and cardiac exams are unremarkable. She is a vegetarian and has some heavy menstrual periods. Hemoglobin is at 8. That's actually super crazy important. If it were normal, this would be a totally different diagnosis. So hemoglobin is at 8, which is low. Hematocrit is low. Here's some other labs. Which of the following best explains the symptoms? All right, so it looks like they have maybe some normal PaO2 and SaO2, but we have some low arterial O2 content. This is at 11%. And that's probably because of the reduced hemoglobin. And the hemoglobin is, of course, the main oxygen carrier. Let's go over the basic science. The O2 content is the hemoglobin times a coefficient times the SaO2 plus a coefficient times the PaO2. And so even if you have normal PaO2 and SaO2, these are just two of the variables here. The hemoglobin could actually drop as well in anemia, and that lowers your O2 content because of that anemia. So these are the 3 factors you should consider if somebody's struggling with their O2 content. So you have normal PaO2 and a low O2 content. It's probably going to be anemia because of that hemoglobin deficiency. You have hyperventilation without hypoxemia. It's anemia because you have a compensatory mechanism to tissue hypoxia. Low oxygen delivery, even though you have the PaO2 and the CO2, is just fine. You have reflex tachypnea and hyperventilation, and that decreases the PaCO2. So some associations that you should be aware of are chronic kidney disease. That's where you have a decrease in the EPO. That makes total sense because that's where the production occurs. Yeah, that's normocytic anemia. Iron deficiency would be a microcytic anemia. You have low O2 carrying capacity. Cancer is marrow causing the anemia. And then pregnancy is dilutional, and lead poisoning is defective heme synthesis. So these are kind of all the associations that you should be aware of, at least for anemia in this particular question. And the pathophys is that you have low hemoglobin, and that decreases the carrying capacity. And so if there's less oxygen that's going to be transferred to your tissues, and you have that normal because there's intact lung oxygenation, it's just that you don't have the things that carry that oxygen. And so the PaO2 and SaO2 are normal, but the CO2 is going to be low. The reason why is there's poor tissue delivery and there's compensatory hyperventilation. And the hyperventilation gets rid of the CO2. And that's the reason why you have normal PaO2 and low CaO2. There's not enough oxygen pressure, there is enough oxygen pressure, but there's not enough hemoglobin trucks. Think about like little hemoglobin trucks that carry that oxygen. And so you get hyperventilation because your tissues are like, I need to breathe, man. Give me some more oxygen. But they can't. And so they have no trucks. And so this is a hemoglobin problem. All right. And so our answer is going to be iron deficiency anemia. And I think that was one of the only anemias listed here. The brief explanation, we kind of went over that. Alveolar hypoventilation. If you're hypoventilating, then you have an increased PO2. So that doesn't make any sense. High altitude would have decreased PaO2, but we said that was normal. Pulmonary embolism would have some sort of a VQ mismatch or tachypnea and also chest pain. We don't see that here. And anxiety hyperventilation, dizziness, tingling, but we do not reduce the arterial O2 content unless it's combined with another pathology. All right, so the real kind of big takeaway here is we got somebody with fatigue, menstrual bleeding, shortness of breath. Everything looks normal, but the oxygen content is low. And if the content is low, then there's not enough hemoglobin trucks that can carry this thing. And so it's just some sort of anemia. The anemia they gave us was iron deficiency anemia, and that's why it was the correct answer. All right, this is a really cool question. Here we have a 40-year-old woman undergoing evaluation for fatigue is found to have low free T3 and T4 levels. All right, so I'm updating that. So she's a little bit older, but she has a high total T3 and T4 level, and her TSH is mildly elevated, and she has recently started estrogen therapy, which of the following best describes how thyroid hormones exert their effects on the tissues. Yeah, this is a really interesting basic science question, and we have to know how thyroid hormones work, like T3, and how it works is that it binds to the nuclear receptor, and that kind of functions as like a transcription factor. And we might have increased TSH, decreased T3 to T4, and this makes us think of primary hypothyroidism, right? So typically that would be like Hashimoto thyroiditis. It's most common in middle-aged women, and also there's autoimmune destruction, and that causes increased TSH from the loss of the feedback. So you have decreased TSH and decreased T3, T4 would be a secondary problem, like a pituitary, or maybe a tertiary problem, like a hypothalamic problem. So there's like Sheehan syndrome, pituitary adenoma. And another scenario that you could also have, and I'm just kind of giving the lay of the land of all of this TSH stuff. So again, this right here would be Hashimoto's. If they were both decreased, then we just mentioned that's secondary or tertiary hypothalamic hypothyroidism. So like a pituitary adenoma or Sheehan syndrome, or maybe a hypothalamic tumor. If you have normal TSH, that's interesting, and you have decreased T3 and T4, then that could be just sick euthyroid syndrome. And that's where you have a low T3 due to illness with a low or normal T4, and the TSH is just not elevated. And so just some other kind of facts to look out for here. Thyroiditis is autoimmune anti-thyroid peroxidase, or the anti-TPO is what's associated there. And the risk also is increased of non-Hodgkin's lymphoma with Hashimoto thyroiditis. In sick euthyroid syndrome, that's in hospitalized patients who are chronically ill. And that's due to a decreased peripheral 5' deiodinase activity, and that causes the low T3, even though you have normal TSH. And then the secondary hypothyroidism, that's like a pituitary disease. All right, so what's happening in this question? Well, here they're just kind of asking, hey, what describes how the thyroid hormone exerts their effects on the target tissues? And the answer is that they bind to the intracellular receptors that regulate the gene expression. So T3 binds there to the nuclear receptors that function as transcription factors. They are amino acid based, but they kind of are like steroids because they're lipophilic character and nuclear mechanism of action. All right, GPCRs, that's like a lysosomal degradation. That's when you have excess proteins. Cyclase stimulation would be with a peptide hormone, and ribosomal binding is seen in mRNA translation. So yeah, your T3s, they are kind of special. They sneak in through the cytosol, go straight to the nucleus, and then the T3 binds to nuclear receptors. So it's kind of like a steroid. And T3 is going to be the activated, T4 is like the pro-hormone. So these, even though they're like amino-generated, they don't sit on the cell surface. They actually go into the nucleus. And so the answer is that they bind with the receptors to regulate gene expression. All right, guys, hopefully you found this helpful. If you like some of these new things that I've incorporated over here on the side, then please let me know. If you like the green screen, let me know. I could also switch it back if you'd like. Take off that green screen. Hopefully this is helpful. Hopefully you guys are crushing step 1. I've also scheduled about 100 different questions. So every single day in the community tab, you'll have a new question. So everybody be sure to like and subscribe for more content, and we'll see you guys later.